Garode McMahon. Garode is our assistant clinical chief and a major clinician in the ICU renal program and consults at the Brigham. He did his medical education in his native Ireland, University College Cork, and followed by medicine and renal training, and then moved to the US in the late 2000s. Ultimately did a renal fellowship with us from 2010 to 2014 and has been a very valued member of the staff. He had been on the biopsy program, the NIH, and has published widely on that and other issues. And today he's going to be talking about diabetic kidney disease.
Thank you very much, Dr. Mount. Disclosures, consultant for Fresenius and Apellis, and had research support from Alexion Pharmaceuticals. So my objectives are to review the epidemiology of diabetic kidney disease, the pathology, pathophysiology, natural history, and discuss treatment strategies to delay progression, which is a lot to do in the next 30 minutes, but I hope I'll get through it pretty quickly. So first of all, I'll talk a little bit about the epidemiology of diabetic kidney disease. Diabetes is the leading cause of chronic kidney disease in the US and worldwide. The overall prevalence of diabetes has increased from about 6 to 10% over the last 20 years as people have gotten older and survived for longer. The proportion with CKD has remained stable. It's about 25 to 30%, which is what we would expect. Although it is the commonest cause of end-stage kidney disease, the proportion of patients with end-stage kidney disease is extremely low, which is the case for all of our chronic kidney disease patients. So the majority die before requiring renal replacement therapy, and the most common cause of death is cardiovascular disease. Type 2 diabetes mellitus accounts for 90% of cases, so most diabetic nephropathy patients have type 2 diabetes. And genetic variation accounts for much of the heterogeneity in presentation, and that's something that we're thinking about and working on at the moment. Outcomes for patients with type 1 and type 2 diabetes mellitus who develop CKD are much worse than for those who don't, and this is a marker of the underlying vascular disease you see in these patients. The natural history of type 2 diabetes. This is from 2017. First of all, hyperglycemia. The GFR is initially high. There's early cellular injury before you develop established CKD, microalbuminuria and macroalbuminuria. Hypertension develops early. Initial high GFR followed by normal, low, and end-stage kidney disease, cardiovascular disease, and kidney complications. eGFR starts to decline generally after about 18 to 25 years, and end-stage kidney disease after about 18 to 30 years, but it's very variable. Diabetes is very common in patients with CKD. Among all patients without CKD, it's around about, or individuals without CKD, it's about 15 to 20%. This is in a cohort of adults. In all patients with CKD, it's about 50%. In patients with CKD stage 4 and 5, it's about 60 to 65%. So it's very, very common. It's the most common cause of chronic kidney disease. It's also extremely common in patients starting dialysis. This is from the USRDS annual report in 2023, looking at comorbidities in patients initiating dialysis. About 60% had diabetes, 22% heart failure, other cardiac disease about 20%, COPD about 15%. But you can see again, diabetes dominates the comorbidities in patients starting dialysis. It is important to note that the natural history of diabetic nephropathy is not the simple micro-macro CKD paradigm. Around about 2% of patients with diabetes have progression in proteinuria every year. About 40% never develop albuminuria, and 60% get CKD without albuminuria. And even in those who develop microalbuminuria, about only 30% progress to macroalbuminuria, about 30% regress, and about 38% remain with microalbuminuria. And this, to some extent, is to do with the use of RAS inhibitors. This is an older study from 2006, so at the time there was nothing but RAS inhibition, and I suspect that some of the regression they saw in these patients was at the initiation of a RAS blocker. But it's interesting when you look at this and you see 60% of patients developing CKD without albuminuria. And, just makes you think, when we think of the classic appearance on a biopsy of diabetic kidney disease, it's those Kimmel-Steele-Wilson lesions, FSGS, but really that's not the majority of patients with CKD-related diabetes. It is important to note that diabetes care has changed over time, and this has been reflected in outcomes in these individuals. Average HbA1c has gone down over 20 years, systolic blood pressure has gone down, LDL cholesterol levels have gone down, use of statins, all of these things have improved outcomes for patients, RAS inhibitors, statins, and glucose-lowering medications, but there are still disparities and important disparities between different racial groups in terms of their access to these medications and their overall achievement of these goals. And what's interesting is, in common, with the introduction of RAS inhibitors, what we're seeing is less albuminuria in patients with diabetes, but more reduced GFR. And some of this is probably a reaction to the RAS inhibition, but some of it also is the fact that, we're seeing more patients with this kind of microvascular disease leading to diabetic kidney disease rather than the glomerular disease that we think of as being pathognomic. What is encouraging is we have seen a big change in outcomes for these patients. So there's been a marked reduction in end-stage kidney disease due to diabetes, particularly in African Americans over the last, between 1996 up to about 2014. And this is a reflection of the use of more RAS inhibition, better blood sugar control, better blood pressure control in these individuals. And, the hope is, as we see the effects of the newer medications bleeding through into the general population over the next 5 or 10 years, that these numbers will look even better. So how does diabetic nephropathy come about? There are lots of different risk factors for CKD in patients with diabetes, comorbid conditions like hypertension, IgA, other glomerular diseases. Socioeconomic factors are important, like lack of access to healthcare, the expense of medications. Genetic factors are extremely important, familial clustering, the presence of APOL1, although this is more of an indirect effect. They take the example of the Pima Indians in New Mexico, where the incidence of diabetes is extremely high and the incidence of CKD related to it is also much higher. Demographic factors are important. Older age, the rates of CKD are higher in women. Obesity is a significant modifier, as is the history of smoking. And of course, there are diabetic-specific factors like poor control of blood sugar. How does diabetes cause chronic kidney disease? There's a lot of different mechanisms, but one of the major problems is this increase in inflammation. So the diabetic milieu itself promotes the formation of glycation end products, pro-inflammatory and pro-fibrotic growth factors, increasing production of reactive oxygen species, increasing renal plasma flow and infiltration with an initial increase in GFR. There's likely an important role of tubuloglomerular feedback in increasing GFR and causing podocyte injury. And eventually, as a result of this, glomerular structural changes lead to albuminuria and CKD. Hyperfiltration is really, really important in patients with CKD. Hyperfiltration is a result, at least initially, of tubular glomerular feedback, where increased glucose reabsorption in the proximal tubule leads to decreased delivery to the macula densa, and that causes intrarenal responses which increase afferent blood flow and increase GFR. This is a really nice study from 2012 looking at outcomes in patients who had hyperfiltration and then gave them an ACE inhibitor and found that the patients who had persistent hyperfiltration after ACE inhibitor initiation predicted future albuminuria. At least helps in part explain why ACE inhibitors and SGLT2 inhibitors are useful in delaying progression, because this reduction in glomerular pressure and hyperfiltration. These are the kind of glomerular changes you've seen in CKD. We've all seen these before. Panel A is normal. Panel B, you've got some mesangial expansion. Panel C, you've got some more mesangial expansions getting a little bit worse. D, you have Kimmel-Steele-Wilson lesions. E, you have microthrombi and necrosis, and then F is a senescent glomerulus. And this is the classic teaching of what diabetic kidney disease looks like. However, it's really, really important, just as I said earlier on, when you recognize that about 60% of patients with diabetes don't have microalbuminuria, but do have CKD. I'm sorry, 60% of patients with CKD and diabetes do not have microalbuminuria. And these patients, when you biopsy them, they do not have a lot of glomerular changes. I have been involved in the KPMP study for the last couple of years, looking at biopsies in patients who would not necessarily have got one before. And these are patients who do not have those classic indications for biopsy, like hematuria or heavy proteinuria. A lot of them just have some hypertension, a little bit of diabetes, maybe a little bit of albuminuria. And what we're finding is the predominant lesion in these patients is microvascular. They might have a little bit of mesangial expansion, but sometimes it's difficult to tell the difference between somebody who's had diabetes for 10 years and has had hypertension for 10 years because they look very similar. What we do see in these biopsies is that these microcirculatory changes precede glomerular changes. And this is what leads to the nephropathy, retinopathy, and neuropathy. You have hypertrophic remodeling of the vascular wall, decreased luminal diameter, increased medial and basement membrane thickness, and increased microvascular permeability. And the end result is these very small ischemic looking glomeruli with microvascular changes, arterial sclerosis, arteriolar sclerosis, and hypertension too, because this causes ischemia, this causes glomerular ischemia, and this glomerular ischemia promotes the secretion of renin and aldosterone and increases blood pressure. And so a lot of the blood pressure we see in these patients is not a concept, is not causing the kidney disease, as Dr. Glassiger said earlier on. The blood pressure is a consequence of the kidney disease, and it's a sign of the stress that's happening within the glomeruli because of ischemia related to the presence of the diabetic changes. This is more what we were seeing in these biopsies. It was absolutely fascinating. So A is a normal biopsy. B is what we really saw a lot of. B is a patient with relatively normal looking tubules, but that tubular basement membrane is thickened. And that was actually probably the most characteristic finding of diabetic kidney disease that we saw in a lot of these patients. C is a damaged looking vessel, and then E is a patient who's got a lot of sclerosis and scarring and some interstitial nephritis related to the scarring as well. And this is a person with a more advanced chronic kidney disease, obviously. As I said, there is a bias in biopsy studies. Most patients getting a biopsy for CKD with diabetes will be atypical. There's more proteinuria, hematuria, more rapid progression. The typical diabetic nephropathy patient almost never gets a biopsy. And so we didn't, at least until KPMP came along, know what the majority of diabetic kidney disease looks like. But we're building that atlas of diabetic kidney disease now, and we're going to hopefully this will help us understand a little bit more about the pathophysiology and how to manage these patients in the future. Here's a classic study from 1993, 52 patients with classic clinical diabetic nephropathy. Only 36% had so-called classic diabetic nephropathy, meaning the presence of Kinnell-Steel-Wilson lesions and a lot of glomerular changes. 31% had primarily ischemic or vascular changes, which is what we're seeing as well. And about 33% had another superimposed glomerular disease. So it's really important to recognize this. All right, going to move on to talking a little bit about diabetic kidney disease progression. How do you define progression? This is a problem. This is a problem both clinically and it's a problem for doing clinical trials. In a population-based cohorts with healthy volunteers, normal GFR decline is about 0.2 to 1 mil per 1.73 meters squared per year. There are not any great definitions of progression and rapid progression. And one of the problems, of course, is that many of the medications that we use to prevent progression or delay progression actually decrease GFR. These have been suggested by KDIGO in 2012. Progression is a decline in the GFR category. But of course, if you start off at 32 and you go to 28, then you would meet that criterion, even though you have a very small change in GFR. Certain progression decline in eGFR category and greater than 25% reduction in GFR. Rapid progression greater than 5 mils per minute per year fall in GFR. The reason why these definitions are important is because how do you do a clinical trial if you don't have a good outcome? And so in the past, this was a major problem with doing clinical trials in nephrology because the outcomes that we chose, if it was end-stage kidney disease, for example, that's pretty much useless because the vast majority of patients will never end up on dialysis anyway. So that's a small subgroup of these patients. And so what you want to know is how do you delay progression, but how do you define progression? What we do know is that the risk for end-stage kidney disease increases as proteinuria increases and GFR decreases. This may seem like a very obvious statement to make, but it's very important. This presence of albuminuria modifies risk. in all risk categories. And this is why there's been a move in nephrology in general over the last couple of years to think about albuminuria itself as an outcome measure for these patients. So how can we delay progression? Dr. Glassick went into this a little bit earlier, talking about blood pressure targets in patients with diabetic nephropathy. Most trials of intensive blood pressure reduction traditionally excluded patients with CKD. The IDNT trial, for example, found a J-shaped relationship between achieved systolic blood pressure and outcomes. UK-PDS found lower microvascular complications with a systolic blood pressure of 144 versus 154. Even saying that out loud seems extraordinary at this point when you think that 144 was the good blood pressure in that group, but that was a much older study. The ACCORD study found no cardiovascular benefit for intense blood pressure control in type 2 diabetes mellitus. There was a reduction in albuminuria, but no reduction in end-stage kidney disease. The SPRINT study, however, this was really the seminal study, and Dr. Glassick talked about this earlier on, found a 25% reduction in cardiovascular outcomes, but in this study, patients with diabetes were excluded, and there was a more rapid decline in GFR in patients with CKD. Post-hoc analysis of SPRINT found that there was an increased risk of acute kidney injury with intensive blood pressure control. However, most cases were mild and returned to baseline. What was interesting about this, though, is that a subsequent analysis found that the patients who developed AKI with the intensive blood pressure control had a much higher cardiovascular risk. What that tells me is that those patients have microvascular disease, and that microvascular disease isn't just existing in the kidney, it's existing elsewhere as well. And so if you get AKI after controlling somebody's blood pressure, you need to think about how much that is a risk factor for other cardiovascular outcomes as well, because of course it's important to remember that these patients generally don't progress to end-stage kidney disease, and what they are dying from is cardiovascular disease. It is unclear if proteinuria modifies this effect because people with proteinuria greater than a gram were excluded from the study. So this is where we stand with the guidelines right now. KDIGO have a draft guideline, which is available, but it isn't published officially yet. The goal systolic blood pressure for their guideline is now less than 120, using standardized measures only. So only if they're a regular hospital blood pressure just taken off the cuff walking in the door is not going to count here. Otherwise, the blood pressure target is less than 130/80. No evidence for CKD benefit, but primarily for cardiovascular benefit. ESC guidelines 2018, blood pressure at 130 to 139, I think these have been superseded. The 2025 ACCHA guidelines suggest a blood pressure of less than 130/80. And the brand new 2026 American Diabetes Association guideline suggests the blood pressure should be less than 130/80, but a target of less than 120 should be considered where possible. So I think that's where the consensus is going right now. Even a couple of years ago, this slide looked very different because there was still a lot of conflict between the people who figured that it should be, as low as it is right now. But I think all the major societies are moving towards the idea that we should be targeting a blood pressure of less than 120. Or sorry, less than 130, I should say. What about intensive glucose control? We know that intensive glucose control in early type 1 diabetes mellitus reduces the risk for microvascular complications. It is less clear for type 2, reflecting the delay in diagnosis in many cases. Strict glucose control in patients with established complications is not beneficial, and there is an increased risk of hypoglycemia. No change in mortality in non-CKD populations. But what is interesting is that it turns out that intensive glucose control actually increases cardiovascular and all-cause mortality in patients with established CKD. So 10 years ago, we were targeting a low A1C in all of our patients with diabetic kidney disease, but that has changed. And again, is reflected in the guidelines. The ADA guidelines suggest a strict HbA1c target in younger patients without complications, so less than 6.5%. But less than 8% in those patients with no microvascular complications or CKD. So that's basically all of our patients. KDIGO recommends less than 7 in patients without any disease, but this is not appropriate for patients with established CKD and risk of hypoglycemia. In the draft guidelines from 2026, they talk about time in range, and this is a new concept in the management of diabetes and speaks to the fact that a lot of people have continuous glucose monitors on these days, so we can keep a much tighter control over blood sugar. This is a really nice from the KDIGO guideline, Diabetic Kidney Disease Clinical Practice Guideline from 2022, kind of talking about the fact that, not everybody is the same. So we really shouldn't be using one target fits everybody kind of role here. If you've got a young person who's got some CKD, but is otherwise really well, has good hyperglycemic awareness, has a better life expectancy, then you probably should be targeting a lower A1C in that individual, even if they have CKD. But if you have somebody who's older, who does not have good hyperglycemic awareness, then you really probably should be targeting that higher range in those individuals. So they're really talking about how it should be more individualized. RAS blockade, single most effective therapy for slowing down the progression of diabetic nephropathy. In the seminal Captopil trial, there was a 50% reduction in death in end-stage kidney disease. ARBs are just as effective as ACE inhibitors. We know this from multiple studies in the 1990s. Can RAS blockade prevent the development of microalbuminuria? No benefit in type 1 diabetes, mixed results in type 2 diabetes trials, but really there's no clear evidence that doing this is appropriate, and the guidelines at the moment do not suggest starting somebody without microalbuminuria on an ACE inhibitor specifically to target the prevention of microalbuminuria. That said, if you have somebody who's got hypertension and you want to start them on something and they've got diabetes, then it's appropriate to choose an ACE inhibitor. Is more RAS blockade better? A consensus study in the Lancet suggested a benefit for dual ACE and ARB therapy. However, subsequent studies showed clear harm. The VA Nephron-D study, increased risk of AKI and hyperkalemia, no benefit. On target, some reduction in proteinuria, increased of AKI and end-stage kidney disease. Altitude, terminated early due to adverse events and no positive signal. And it turns out that this consensus study that was published in the Lancet was unfortunately fraudulent, where the patients were made up. And it just goes to show the damage these can do, because for about 3 or 4 years in the 2000s, we were all putting people on dual ACE ARB therapy, and we probably caused some harm as a result. So these are the key RAS inhibition trials. Just wanted to put this up here for your review later if you want to. The RAS guidelines, ACE-ARB given to patients with diabetes and microalbuminuria to delay progression. Consider ACE and ARB as first-line antihypertensive in patients with CKD without proteinuria. No role for prevention of albuminuria in patients with type 1, less clear in type 2. Dual blockade is not appropriate. May be a role for dual blockade in severely nephrotic patients, but this remains unclear. And continue ACE inhibitors where possible until the patient starts renal replacement therapy. This is really important. Lots of failed therapeutic strategies since renal. This is an older slide, but I keep it in because it reminds me just how much progress we've made in the last few years. One beautiful example is bardoxolone. This was a phase 2 trial of a novel prostaglandin agonist that was noted to have an increase in GFR in preclinical cancer studies. In this study, there was a dose-dependent increase in GFR maintained through 1 year, but there was also an increase in proteinuria, which should really have raised some pretty strong red flags about the idea that this was just increasing intraglomerular pressure. Subsequent phase 3 trial of 2,400 patients with diabetes and CKD, higher GFR and proteinuria in the bardoxolone group, terminated early due to an excess of heart failure and cardiovascular death in the treatment group. CKD studies are hard, unfortunately. What is important, and this has happened in diabetes, but also in other glomerular diseases, is that up until about 10 years ago, we were trying to use hard outcomes for these trials. And this is very, very difficult because, as I said, fewer patients end up on dialysis. But over the last few years, the FDA has allowed us to use albuminuria as a surrogate outcome marker for all kinds of glomerular diseases, including diabetes, because we know that a change in albuminuria is associated with a change in end-stage kidney disease, and it's a very strong association. And a lack of change in ACR is associated with no clinical benefit. So as a result, now we are using change in albumin-to-creatinine ratio as a direct outcome measure in patients in these kinds of clinical trials. Newer therapies. This is where everything gets good. GLP agonists, critical metabolic regulatory program, enhances insulin secretion, slows gastric emptying, decreases appetite stimulation in the brain, improves glucose control with no risk of hypoglycemia, low risk of cardiovascular events in high-risk patients, and significant weight loss. The SUSTAIN 6 trial, about 3,000 patients randomized to semaglutide or placebo. Primary outcome was cardiovascular. It was a 26% reduction in major adverse cardiovascular events, no change in GFR, but there was a change primarily in albuminuria. The LEADER trial, almost 10,000 patients randomized to liraglutide or placebo, 22% reduction in renal outcomes driven by a lower rate of onset of persistent microalbuminuria. Low absolute difference, but there was certainly a benefit and a clear cardiovascular benefit, which was higher for those with CKD. So what I tell patients who are asking me if they can start a GLP-1, I encourage them, if it's something that they want to do, or if something their doctors want to do, certainly, I encourage them that it's not going to do them any harm and could certainly be beneficial in preventing progression of albuminuria at least. ADA recommends adding a GLP-1 to patients on RAS blockade and an SGLT2 inhibitor for cardiovascular benefit. The blood sugar lowering ability is maintained in advanced CKD, unlike SGLT2 inhibitors. KDIGO 2026, which is still not published, recommends adding after a non-steroidal mineralocorticoid receptor antagonist. Endothelin receptor antagonists, so endothelin-1 increases in CKD, leading to multiple adverse consequences, including fibrosis, mesangial cell proliferation, podocyte injury. The avosentan trial, there was a decrease in ACR, but there was an increase in heart failure due to sodium retention. The study was stopped as a result. Subsequent study called the SOLAR trial using atrasentan, a more selective endothelin-1 receptor antagonist, is an interesting study because it did something that most studies don't do, which is it tried to get rid of the patients who were going to do poorly. So what they did was they did a run-in period where they put patients on the drug, and if you did not develop edema and had at least a 30% reduction in ACR, then they continued in the study. And what they found was a significant reduction in the renal endpoint, but higher rates of heart failure and cardiovascular mortality in the atrasentan group. I'm not saying this is something we should be using routinely, but it's just interesting to think about this way of doing a clinical trial, because we talk more about individualizing care, and this is the kind of thing we're thinking about when we're talking about individualizing care, finding patients who are responding well to something and then continuing it. Non-steroidal MRAs. Steroidal MRAs have been used to treat diabetic kidney disease, but their use has been limited by hyperkalemia. Finerenone study patients with diabetic kidney disease, 3,000 to 5,000 milligrams of albuminuria. There was a reduction in the renal outcome from 21 to 17%, a marked reduction in albuminuria, and a relatively low prevalence of hyperkalemia. So the suggestion is we add this in patients with diabetes with persistent proteinuria despite RAS and SGLT2 inhibitors, and probably in non-diabetic patients too. It's coming. There's some studies in process at the moment. SGLT2 inhibitors. Glucose is freely filtered in the kidney, reabsorbed in the proximal tubule. In the absence of hyperglycemia, all this glucose is reabsorbed. SGLT2 inhibitors block glucose reabsorption, leading to glycosuria with low serum glucose levels. Lots of different potential mechanisms for the protective effects of SGLT2 inhibitors in the kidney. Abolition of hyperfiltration, of course, through restoration of TGF, altering metabolic fuel energetics, stimulating a fasting-like condition, inhibiting sodium proton exchange, reducing oxidative stress in the kidney by greater than 50%, blunting increase in angiotensinogen, reducing inflammasome activity in the kidney. These are really remarkable drugs. How do they reduce TGF? So if you have normal TGF, what happens is you have glucose and sodium reabsorption in the proximal tubule, and you get a reduction in delivery to the macula densa as a result, or normal delivery to the macula densa as a result. In patients who have increased glucose filtration, you will have more sodium and glucose reabsorption. This decreases chloride and sodium delivery to the macula densa, and the kidney senses this as a decrease in perfusion, and so will stimulate increased GFR as a result. SGLT2 inhibitors, by blocking glucose reabsorption, increase sodium and chloride delivery to the macula densa and cause normalization of GFR. EMPA-REG study, 7,000 patients randomized to empagliflozin or placebo, eGFR greater than 30, no ACR, 14% reduction in cardiovascular disease, 44% decrease in the primary renal outcome. Relatively low rates of renal outcomes in this study because it wasn't powered for them, but it certainly gave us pause. Credence, 4,400 patients with albuminuria and a GFR greater than 30. The trial was stopped early due to a 30% reduction in the primary outcome, end-stage kidney disease or doubling of creatinine after only 2.5 years. There was an initial rapid reduction in both ACR and eGFR, but the overall slope of decline in eGFR was lower in the SGLT2 inhibitor group. And this again speaks to the difficulty of doing these studies, because if you just use GFR as an outcome, this would look bad, at least in the first year. SGLT2 inhibitors also reduce renal and cardiovascular outcomes in non-diabetic patients, and they really are the standard of care for the management of both diabetic and non-diabetic proteinuria kidney disease. EMPA-KIDNEY study, 6,600 patients with CKD, no requirement for albuminuria, 30% eGFR less than 30, 50% to diabetes, again, a marked reduction in primary outcome, and the study was stopped early for efficacy. However, no effect in the primary outcome in the large group in the group of patients with an ACR of less than 300, largely because of a very low rate of the primary outcome in this group. It is safe to use SGLT2 inhibitors at lower GFR, but effectiveness is less clear. Notes of cautions: ketoacidosis, don't use in patients with type 1 diabetes, and certainly UTIs are a big problem. We see a lot of patients developing UTIs and unable to take them. Real room for improvement. So this is from 2023. We need to get more patients using SGLT2 inhibitors. The percentage of patients is still relatively low, at least in 2023. Hopefully now we'll see these data will look a lot better at this point. A couple of slides here on practical guides for initiating SGLT2 inhibitors. I'll just leave these in the slide deck for you to look at afterwards. Another one on the holistic approach to managing diabetic kidney disease in 2026. So this is from the KDIGO guideline in 2022, and suggesting SGLT2 and RAS inhibitor as first-line therapies with GLP-1s and non-steroidal MRAs after this. And this is the new 2026 ADA guideline, again suggesting RAS first, then SGLT2 inhibitor, then GLP-1, and then after that a non-steroidal MRA. I'm not sure if that's what we're going to say as nephrologists. I think the MRA will probably come first. So in summary, diabetes remains the #1 cause of end-stage kidney disease across the world. It takes years to develop. Microalbuminuria per preserved GFR is usually the first sign of diabetic kidney disease. RAS blockade is beneficial in patients with diabetic nephropathy. SGLT2 inhibitors are the biggest advance in diabetes since ACE inhibitors were introduced and are now standard of care. GLP-1 and MRAs are second-line treatments for diabetic nephropathy, particularly with proteinuria. Thank you very much. Sorry for going over.
Thank you, Garode. Hopefully you can replenish your oxygen deficit between now and the question and answer section.